People are much more than just an accumulation of parts. So that's why I wanted to make sure for the new patients, I was able to get to learn and know each one of their own unique full stories. So I literally review in utero to present for every single one of them at that new patient visit, which knowing that, for example, if I'm seeing a 2-year-old, they likely haven't had as much time to develop as much history as someone who is in their 90s. And I treat patients of all ages, including.
So, what if you could practice medicine, but on your own terms? No insurance, no rushing, just real healing. Well, Dr. Shanda Dorff did exactly that. She walked away from the typical system and now has up to a 13-month wait list as a fully out of network practice that serves complex patients with the time and care that they really deserve. Her story is proof that there is another way. So, welcome to the Med Story podcast, and let's dive in. Welcome, Dr. Dorff. I'm happy to have you on.
Hi, it's a pleasure to be here. Thank you.
So, I want to get right into this. I want to dive into that moment in your career where you were just like, you know what? I'm fed up with this. I am going to step away and I'm going to start doing my own thing. Can you kind of zoom into that exact moment and what was going on in your brain?
It was actually a combination of stuff with work as well as stuff in my non-work personal life because I had recently dealt with the loss of my mother, who was always a wonderful, amazing person and influence in my life, who had actually passed away as a result of medical malpractice, negligence, and wrongful deaths, as determined by the courts. And I, when I was pregnant with my now 7-year-old, who was an incredible spirited person herself and has a lot of her grandmother in her personality, I had some health issues and had to go out on medical leave a little bit early before I had her, able to meet my own health needs. And while I was out on many of the patients that I've been working with for several years that were very complicated with multi-system diseases that I absolutely adore, and many of them I knew their whole life stories very well, and they were needing care while I was out, but their access to cares is very limited due to a combination of not very many clinicians being familiar with the conditions or being comfortable working with it, but also some various different administrative limitations placed on different clinicians by ones that really aren't making any of the direct care decisions, but ones that were having to do more overseeing and regulating, similar to try to make it where everyone was able to be fully replaceable or could cover for anyone else fully, which also was really limiting scope of practices for many clinicians in an effort to be the most efficient from a business standpoint. And so shortly before I went to come back from maternity leave, I found out that the organization that I absolutely adored and still absolutely truly love and adore many of my former coworkers. We have many mutual patients in common, and they are wonderful, amazing people. I found out decisions made well beyond their level had decided they weren't going to be able to allow me to be able to continue caring for those particular conditions when I would return from my maternity leave, which initially I thought, well, I'm going to miss doing it, but I'm not someone that's jealous or territorial or anything like that. And what mattered most to me is the patients could get the care they need regardless of where, and it did not have to be me. And so that's when I then worked to try to see if there was other options for care and further reaffirmed there's very limited access to care for the conditions. And upon my return, I found that the majority of the patients had had significant deteriorations in their health just because they weren't able to get some of the cares that they needed. And despite trying vigorously to be able to get access to cares for them, a few of them were able to get access to cares in other states. But the insurance, with a lot of paperwork, would only be willing to consider reimbursement for the medical stuff, but not any transportation or lodging, which really limited many patients to even be able to get cares. And this was before the typical days of telemedicine being much of an option. I then made the very difficult decision that as much as I absolutely adored all of my patients, complex as well as not as complex patients, and loved my former coworkers very dearly, that I felt really an obligation to my Hippocratic oath of first do no harm by not denying cares, but also felt like I wouldn't really be able to sleep at night or to tell my children to stand up for themselves and what they believed if I didn't feel like I did that for myself and for my, as well as I also knew that after having lost my mother, that I didn't want to risk any of my patients or their loved ones having to experience something that could have potentially allowed them to have a much greater, not only quality of life, but also quantity of life if they'd been able to get access to necessary cares. And so that was when, after having meetings on levels of the organization, ultimately ended up deciding I really didn't day notice. And so at one of those meetings, I did give them my 90-day notice, but still wish them all very well. And like I said, I really adore all of the people as individuals. They are wonderful. all the ones I work with, I consider very close friends, as well as then set up to start my own practice where 90 days from the date of that last meeting happened to be Halloween, and so it happened to be fun. So then I went to work in costume, always a fun way to go to work because I happened to be Glinda the Good Witch of the North, and then the very next day, I went to be my own separate entity just because I felt that my patients had already had too long of a break where they hadn't been able to get access to the cares that were necessary. So if I was to take additional time off between leaving the one practice and opening my own, I feel like that would be doing a disservice to patients that had already been waiting on me since some of them since I first went on that medical leave during the pregnancy.
So I'm guessing that took a lot of bravery from you. And when you decided to go off and do your own thing, did you start thinking that you were going to start by accepting insurance, or did you always know that that wasn't going to be an option for you?
Initially, when I started, the only insurance that I was working directly with was Medicare. All of the others were direct pay, and that was mainly after talking with some other colleagues in other states, as well as some in other countries that I knew who worked with some of these same conditions that found ways that it was able to work for them to be independent, so I was able to learn a lot from them. But also, I knew that with the typical insurance model, there's very limited duration of time for appointments, and the way that I actually chose to set up scheduling and timing was take into account all that I work with and all that I do, and then just what was at that time build rates. And so because I know each patient is different and their story is different, while in the condition I work with, there are some things that overlap, but there's definitely unique aspects to every person and people are much more than just an accumulation of parts. So that's why I wanted to make sure for the new patients, I was able to get to learn and know each one of their own unique full stories. So I literally review in utero to present for every single one of them at that new patient visit, which knowing that, for example, if I'm seeing a 2-year-old, they likely haven't had as much time to develop as much history as someone who is in their 90s. And I treat patients of all ages, including also help with consultations and with ones that are in utero still to help guide managements that way too. So that's why I chose to set up a flat fee for the new patient visits just to ensure that they didn't have to feel like they were being rushed or trying to race through or omit things that they were billed based on time because what they may not realize as significant, or they may think is fine, I might actually think is really important to what we're working with or might show stuff that has been affecting more aspects of their life or have been lasting longer than what they initially realized. And so that's why I wanted to make sure that it was the same and it wouldn't potentially risk seeming like any type of ageism or discrimination by ones who are older or just who have had a lot more challenging health history that would cost more if it was billed based on time or anything like that for that new patient visits. That way they know that no matter how much time that they need, I'm there for them. Typically, it's around 3 to 4 hours, but some have been longer. Versus for the established patients, I quite literally chose the rate that I determined after I got the EOB or explanation of benefits from one of my own medical visits where I went to see my doctor and he was in the room for less than 10 minutes, but because he ordered one vaccination for me and one lab test, that made it a level 4 in terms of medical decision making. And I know from a time standpoint, a level 4 can go up to 39 minutes and my insurance was billed $340. And so I thought, well, even though he was there less than 10 minutes, I know technically a level 4, I know the time duration was billed based on time would have been up to 39 minutes. And so that's how I decided to have the timed visit rates be based off of the total amount of time in minutes of free 5 minutes per week. So subtract 5 and then $10 per minute after that. So that's how I ended up getting to the $340 for level 4 if it was at the maximum duration of time. I know that in general, it's often easier for people to understand things if they're billed based on time than based on complexity codes. And when I'm working with patients that all of them have complex histories, that's why they end up coming to me is because they're needing help and care for stuff that's not super easy or routinely done, that they would all be considered more complex. I want it to be something they could understand, but also where they wouldn't have to feel as guarded or reluctant to ask questions because they do have a free 5 minutes every week, use it or lose it, for any questions, updates, placing orders, reviewing results. And it just makes it easier for me to be able to schedule my time that way, but for them to understand the billing too.
Okay, I hear you. And I think that's really smart because one of the biggest challenges that people have with the current model is the price transparency and they going into it and not knowing how much they're going to be billed even through insurance and after a session or an appointment. So I think that's really wise of you. And so, how did you find your first patients for your practice?
Because I'd already been working with so many of them in the larger practice prior, and the organization that I was with previously wasn't going to allow for the cares for those specific conditions. The patients were absolutely welcome to continue following there, but just like some organizations, for example, don't do bone marrow transplants or don't do, like organ transplants or things like that, but the patients could still be seen for other things, whether it be, their asthma or a routine health checkup or wellness visit. The patients, many of them who are needing cares for those conditions followed me and were continuing to maintain care through insurance-based systems for other needs. And then things just travel very quickly via word of mouth. Also, as you're aware, in the internet era days now and social media and things like that, where I'm not part of any of those specific groups, but I've heard from patients that they've heard or seen my name in various different patient forums on social media. And I think that that also spread very quickly. I'm also on some national, international organizations. And so patients have sought information or resources from those organizations and have been directed to me that way as well.
Yeah, okay, that makes sense. And honestly, I think you're a prime example of if you treat the patient of how they deserve and give quality, valuable care, then that's going to end up being a self referral process for you. And you said to the point now where you've actually built out a wait list that's up to over a year long. And so I could see this, I could see the service that you having being really valuable, giving patients the time that they deserve. But do you feel that this is a scalable solution for other providers or the healthcare system as a whole?
I think it really depends on the area that they're in and the types of conditions that they are working with. So, take for example, if you're wanting to do things similar to like what might be at some different shops, whether it be just finding out, do you have strep throat? Do you have a bladder infection? Are you pregnant? Yes or no? Where it's just very quick, simple, in and out labs. They probably would not do as much directly that way if they're because insurance will often cover those types of things routinely, and they're able to be very quick. A matter of fact, a lot of larger organizations also really like being able to have those because they are such fast turnovers, able to see many more patients a lot quicker, sooner, and so they can generate that much more revenue that quickly if they're working with the insurance model. First, if they're going outside of the insurance model, there's a few different options. Mine would be considered more of a concierge practice just because it's more like just based on the individual visits as opposed to like a direct primary care or subscription-based type of model, which some definitely do and are very successful with, where patients just pay a certain dollar amount per month to be able to essentially have the clinician on retainer on there. I have considered that. It's just a lot easier for patients with the type of work that I do for them to just be able to budget or know based on time and follow that way because they need to be able to have access to the resources, but they also understandably want to be able to have things where they can kind of keep tabs on the budgeting. And that's why some will even schedule, like weekly 5-minute check-ins until they've been able to get their questions answered to maximize their free time and avoid out-of-pocket costs on there, which is entirely fine. I just want to make sure that their needs are met.
And so, is there a top 3 to 5 conditions that you typically are specializing in now, or is it kind of the whole spectrum of care?
Well, I can do the whole spectrum of cares. The conditions that I primarily work with are connective tissue diseases, such as the different types of Ehlers-Danlos syndrome, as well as Marfan syndrome, also mast cell activation syndrome, dysautonomia, and POTS, which is postural orthostatic tachycardia syndrome. I do work with other things, but those are the main ones.
And then have you gotten any resistance from someone saying, "No, I don't wanna pay out of pocket for something like that," or have they been willing to happily?
I have had a few that have done that where they then said that no, they weren't going to schedule, which is entirely fine, absolutely their decision, but then most of them actually did end up calling back months or sometimes a year later to schedule, but then it was so much farther out that some of them were frustrated they weren't able to be seen right away, but that was because they didn't schedule initially and things got booked up, and it's not fair to other patients that are wanting to be seen for us to hold a spot for someone that has said that they are wanting to go elsewhere and then may or may not come back later, but many of them have found, unfortunately, the options are very limited. It has been a significant increase, however, in the last about year and a half, at least for those in the state of Minnesota where I'm physically located, though I'm licensed in Minnesota, North Dakota, South Dakota, Wisconsin, and Maryland. There was a law that took effect January 1st of last year, Minnesota Statute 62Q, as in Queen .451, the Rare Disease Act or Rare Disease Mandate, which states that insurance companies, whether they be private or commercial, state-based insurance, but not Medicare because the state law cannot supersede a federal law, and not those that are self-insured, but all other insurances must grant in-network reimbursement for the care for rare disease. And all of those conditions are in the National Database of Rare Diseases. And so it does allow them to get reimbursed as most of the time. And then others previously, when they were not able to get access to care in network, were being able to get reimbursed, excluding those with Medicare or Medicaid under the Affordable Care Act, because the Affordable Care Act requires what's called network adequacy or adequacy of network, which states that if there is access to care in network for the condition that the member has, then the insurance has met its obligation to be recognized as an insurance at the federal level. However, if there's no access to care in network, then that's when, in order to be compliant with the federal law, the insurance must then grant an exception. Some call it a gap exception, some call it an in-network request form, different names for different companies, but it all ultimately just means that they're going to make an isolated exception for that particular member to allow them to get reimbursed from my out-of-network care by their insurance because there's no access to care in network, which usually ends up having to go through
Oh,
prior
okay.
authorization
Interesting.
and an appeal just to be able to prove to the insurance that, we really appreciate the network that you've got, and it's allowed us a lot of care for things, which is great, but it's just not allowing our needs to be met for this particular condition. And that's why it usually requires having them provide the member a list of every single option they show in network and then verifying whether or not those options do indeed diagnose, treat, and or manage the condition or not. And if none of them do, then that's when they've got the proof to be able to go back to the insurance on appeal to show that, you know, thanks, but I'm still needing the care out of network.
Okay, I got it. And so what's your vision for this business? Where do you want it to be in the next 3 to 5 years?
I would like to be able to have other clinicians that understand either are treating the conditions either with myself to help with the patients or having some of their own practices, or even if it's larger organizations, that's entirely fine too. Just I want to be able to make sure the patient's needs are able to get met. And that's another reason why I also teach different continuing medical education lectures and stuff about it, just to try to be able to improve access to care for the patients and for clinicians and to improve knowledge about it and to help with patient advocacy.
Oh, it's an amazing mission. It really is. And I think the work that you're doing is so important because oftentimes these people with these rare conditions get left out to dry and they're left hopeless. And so it probably means the world not only to have access to you, but then someone that's going to sit down for several hours to truly understand what's going on. Like that is an amazing thing. It really is.
I actually feel very privileged to be able to get to know them and to be able to help them and watch their journey as they are able to be on the road to recovery and improving their quality of life. The conditions that I work with are not curable, but they are treatable. And so it just means that while I can't do like a one-time pill or one-time shot and be done, never have to deal with it again, they're very much able to be managed. Some complications are able to be prevented. Others are able to be better treated when identified early. But I just feel like I've been very privileged to be able to get to be involved in these patients' lives. And so many of my patients are absolutely amazing. And I adore every moment of getting to work with them and know them and their families.
Ah, that's so cool. That's so cool. So if someone's listening to this, either if a provider's listening to this that's thinking about starting their own cash out of
Mhm.
practice, or even if someone has one of these rare diseases and wants to like reach out to you or find out more about you, where can they go?
So they can go directly to our clinic website, which is complexcaresmn.com. So COMPLEXCARESMN.com. Or they can also send an email to your team at complexcaresmn.com.
That's amazing. Well, Dr. Dorff, I appreciate the work that you're doing. I mean, I think we need to continue to get innovative like you have done and to give patients the care that they deserve. So thank you so much for coming on. I really appreciate it.
Thank you so much for having me.
Of course. And so if you are a healthcare provider that is stepping outside of the standard medical model and figuring out ways to disrupt medicine in a positive way, then make sure to reach out to us because it's important to tell great stories like this that Dr. Dorff has. Then you can reach out to us at medstorymedia.com/podcast. Then we'll see you in the next one.